Good evening.
Good evening, Alexandra. How are you?
I'm well. How are y'all doing this evening?
We're doing good.
Good,
People
good,
are
good.
still joining, but I wanted to
Excellent.
thank you so much for agreeing to do this for us.
My
Uh,
pleasure.
as people are waiting to sign in and other people are adding, we have some people that are going to be watching the recording just because
Oh,
they have a time
awesome.
conflict. But for
Yes.
those of you who are online, I just wanted to mention that we're very honored to have Alexandra Armstrong with us. We consider her a personal friend of our family. She's been a tremendous help to us with LEL and with Yonadav. And I think one of the interesting things about our synagogue, Congregations of Har Israel, is in many ways we're very unconventional. We're very traditional when it comes to Jewish observance, but we have a lot of unique families and individuals. And in many ways, I think it's sort of a golden opportunity because not all communities can be as receptive to people that have certain uh, challenges, unique perspectives in terms of their life. And I think this issue of autism, the spectrum, it's something that in many ways is so much it's very much needed, right? There needs to be an understanding, I think, in the greater community, not just for the sake of those in our own synagogue that have family or they themselves might be on the spectrum, but because it's something that we see in the Jewish community that is actually quite significant. And one of the things that we want to do as a community is position ourselves as being open and receptive to individuals that maybe need a little bit more uh, support, and some of the things that we can do to foster that kind of environment so that they feel connected religiously, spiritually, and open, within our community. So, and safe. My wife is adding safe, which I think is very appropriate. So I think we'll
Mhm.
wait maybe just a few more seconds, and
Oh, we're good.
yeah, and we'll start in just a second here.
And how long do we have this evening?
I think we basically budgeted an hour. I thought
Perfect.
about 40, 45 minutes for you to
Mm-hmm.
talk and then whatever questions are raised. I know that we have a
Absolutely.
second session in the future, but
Yes.
whatever you feel comfortable sharing, I think it'll be greatly appreciated by us.
Absolutely. I'm so glad to be here. I feel honored to be here.
Thank you.
Yes. Will there be a function for me to share my screen?
Yes, let me
Oh,
see.
there it is, I think. The green one on the bottom.
Yes, under the
Okay.
more option.
Very
Yep.
good. Hmm.
So
I'll do
I
that
think,
when it's time. Yeah.
okay. So I think at this point we can go ahead and get started. And if anybody comes in, they can just join us as we're in process.
Okay, let me make sure that's doing what I need it to do. There we go. Okay, I think it is. And I think we have closed caption um, for anyone who needs that, right? Do I need to do anything on my side
No,
for that?
it's showing up on my screen.
Perfect. Very good. Okay, so grateful that everybody is here today, and this is such a fabulous topic. For some people, it feels like it's a difficult topic um, because sometimes it can come with situations from the broader community where there's a lack of understanding and a lack of a shared experience about this unique condition and about the spectrum that it's on. So, we certainly want to be mindful of that. I'm going to make a little shift with my computer here and see how that runs for me. There we go. It starts with building blocks, y'all. It starts when our kids are little and from the very beginning, from the time they're conceived, really, the process of nutrition, environment, all of those things are building blocks for how our kids grow. And yeah, we want to be mindful of um, how we handle whether an infant comes into this world prematurely or right on time, or if it's a little bit of a delayed delivery, or if it's a C-section. There are lots of things that can affect the initial arrival of this gift of a child, right? So, um, my role in helping families is I should share, I'm Alexandra Mary Armstrong, licensed professional counselor. I have worked in the autism field for about 30 years. Um, I've seen the conditions of how people have been maltreated when their condition is not adequately discerned, right? And so part of the reason that we have a couple of different sessions for us is so we can look at, as a group, how can we really assure that our children and sometimes ourselves and our adult loved ones, that folks are really attuned to the status of their own brain health, because that's really where it kind of all begins, is the status of the brain health. So we do want to define autism, and we want to look at the prevalence and the causes and the risk factors. We want to identify signs and symptoms. And um, not in this session, but in the next one, we'll likely do a little case study. We'll discuss when there may be co occurring situations, co occurring mental health conditions. We're also going to identify some screening and diagnostic tools. Now, y'all, the screening and diagnostic tools that we'll go over, sometimes we have a tendency ourselves to go try to do those on ourselves and see where we fit into that. Um, that if we're round and we're trying to fit into a square peg, or if we're, a square and we're trying to fit into that round. Um, so we always approach that with caution, right? We always want to have someone else to look at that with us. So, but we always want to have treatment options, ways to mitigate where the autism might be misunderstood in different arenas of a human's life. And we'll certainly, at each time that we visit, we'll have time for some questions. If I know the answers, then I'll share them with you. If I don't, I'll take good notes and we'll share them back, so that we can be ahead of that. So those are some of the things that we want to make sure that we do while we're here today. So, does it ever look like this when you're trying to figure out the world? So many things attached and connected, but we're not really sure how they're attached or connected. We just want to see how that works. So, there are some possible, science tells us there are potential causes or risk factors for autism, and it is a combination of genetics and environment. Um, Genetics are implied by science. Now, there are some especially significant genetic implications that we have to think about in terms of historical trauma and intergenerational trauma. And I say that because genetically, someone may be predisposed to autism. It might be in the gene pool that they are from, but an individual might not have it while their family members have it, right? Um, but also genetically, if there is a series of events over generations that impact the the stress alarm system in individuals, that situation of multi-generational impact can affect the brain and affect the genes. And sometimes some of the behaviors associated with autism can look like acute traumatic stress disorder or post traumatic stress disorder. So, this is a really important reason for us to look at when we meet with children, that we don't make an immediate diagnosis, that we really do look at the family tree, the family experiences, and the ultimate diagnosis is generally made by the child's primary care physician. Now, why would that need to be? Now, a licensed professional counselor can make that diagnosis and document it on a psychosocial history. A psychologist can also do the same. Um, but in the event that autism um, is on the continuum that it is, if it presents disabilities, in order for it within our United States federal government to be um, treated as a disability, um, then it has to be a primary care physician or a psychiatrist that makes that definitive diagnosis. And that's because the federal government then is going to provide a certain amount of funding to support a family that might have a child that has a level of autism that is going to have some unique needs for the duration of their life. Probably a better example might be an individual who has cerebral palsy. Depending upon the level of cerebral palsy, how much that person can function in their regular activities of daily living, or how much help that individual person might need, the federal government operates the same way, that there might need to be a primary care provider, the child's physician, that makes that diagnosis. And because that individual may have issues with being able to walk, toilet, shower, carry their own books, grocery shop. So when there's going to need to be um, a variety of supports around an individual person. It needs to be a medical doctor with an MD or a doctor of osteopathic medicine called a DO. Um, and so those are the two primaries that can make that diagnosis. And they are often going to want the records from a therapist, a counselor, someone who conducted the initial assessments, and take a really good look at that. Now, there are contaminants that are being studied that, as a society, specifically in the United States, the Center for Disease Control um, has not ruled out that lead poisoning um, to a young child can result in autism. And so you might think to yourself, well, how might my child be exposed to lead? Um, well, in the United States, homes built before the 1960s, unfortunately, it was less expensive to make paint with lead. And so a lot of homes that were built before the 1960s, um, if people were raising their children in those homes, you know how kids they might chew on the base of a windowsill, right? It's kids explore the world with their mouths, and we can't, we're not with them 100% of the time. And a lot of the cases that the Centers for Disease Control have found where there was a contaminant, it was lead where a child had chewed on a windowsill. I mean, think about how high those are off the ground. It's about the height they are when they're beginning to walk, right? It's about 18 to 24 inches, and it's just about the right height for their mouth. So now, in the world we live in today, that has been banned. Paint is not made with lead any longer. However, in the 1990s, you may remember this, or this might be the first time you're learning about this. Um, you may be familiar with the little matchbox cars that kids play with, and they have an orange loop that goes around and around, and they can attach it, and they can make their own big racetrack, right? Um, well, for a long period of time in the 90s, um, those little matchbox cars were being imported um, from Japan and China, and they were being made with lead-based paint. And a lot of children in the 90s um, played with those toys. And certainly because kids explore things with their mouths, the parents noticed within a short period of time that there was a change in their child's behavior because lead isn't intended to be in the human body and especially in the human brain. And so those are some places where we might see that that it can happen. Um, you may not be aware of this, and I don't want this to alarm anybody. I just want you to be aware of it that our Attorney General, oh, his name just went right out of my head. Oh gosh. It'll come to me. But our Attorney General recently filed a lawsuit against Tylenol because there is evidence that Tylenol was inappropriately marketed to pregnant women as a safe remedy for aches and pains while pregnant. And so our Attorney General in Texas and some other states have gotten together to put together a class action lawsuit because of that. Now, I will keep Rabbi Juan aware of that and what else we learn, um, because that is a situation where people they ought to know what's happening and they ought to be able to get the services for their child if they notice something significant like that that changes, right? So now those are all evidence of things that might happen with a child, but there are prenatal and maternal risk factors, Tylenol being one of them. Um, in the world we live in today, there's not a lot of risk for a woman to ingest lead, but there's still research being done on other contaminants. And so it's really important that women talk about their health needs with their OB-GYN doctor or their midwife, whomever that might be, and to be mindful of where you might travel while you're pregnant because there are additional contaminants um, that could be in other countries that we're just not aware of. So we certainly want to be mindful of that and how that might affect a mom who's carrying. So, did I went a little bit too far? So, what is the prevalence of autism? Well, the Centers for Disease Control says that it is 4 times more common in boys. And that reference is not specific to by contaminant or by genetics. It just falls that way, that it's 4 times more common in boys. Um, and that 1 in 36 8-year-old children living within the autism network um, identified with ASD, the autism spectrum disorder, in the year 2020. Of those, about 17% of those kids were were in a situation where the continuum of the autism looked like they might need um, lifelong disability supports because of the trajectory of how the autism had manifest in that particular person, right? Many people who are on the autism spectrum will be able to work, go to college, function, be in relationships, um, and have those types of quality markers of life. Um, but some are going to need additional supports. And um, and so then we work together with physicians and counselors to help assure that those supports are available all along the way, right? So, um, but it's not all doom and gloom, is it? It's not all doom and gloom. We know that many children that that are on the autism spectrum or have developmental disabilities or are being monitored for developmental disabilities, um, they can be a lot of fun. I can share with you from my own personal experience. I have twin sons who are 35 years of age, and they were both assessed for autism when they were young. Um, and it really came about because of teachers who had felt like there might be a developmental disability with both boys. Um, but they're 35 years old today, not like their birthday today, but they're 35-year-old men. They run their own households. They are espoused, and yeah, one is a landscape architect and one is an insurance salesperson. And were there some struggles along the way? Sure. One of them needed more special attention um, in public. So they both attended public school. Um, and one of them needed more of the special education supports, especially with reading comprehension, um, because there was a blend of dyslexia. Now, that goes into that co occurring condition where can a child have autism and have another condition? Absolutely, it can happen. Sometimes kids may be on the autism spectrum and um, they may suffer from ADHD, or we think that they're suffering from ADHD, but maybe they're grieving and it's coming across as anxiety in some way. So it's really important to assess those things so we don't label kids, and especially so we don't put them on any kind of medications that are not going to be the right remedy. Um, yeah, if and kind of the way that that it's not ADHD, if you put them on an ADHD med and it doesn't work, then it's probably not ADHD. It's probably a response to something emotional going on in their family. And that's perfectly okay. Happens in all families, for sure. That's why we have grieving periods for 6 months to a year after the loss of a loved one. And we want to teach our children how to navigate those too, right? So we do want to bring about that there are some, when you think about uh, how it's emerging, which race might be more inclined. Well, we see that the white or Anglo-Saxon is at 24.3%. Your A/PI is your Asian Pacific Islander. That's 33.4. Hispanic 31.6, and African American Black 29.3. So this would be the values indicative per 1,000 children. And that's in the time that we are now. These were measured for in 2023, 2024. So it's pretty specific data that supports that it is increasing. Well, why is it increasing? Is it just increasing because now we know what to look for and we're concerned for it? And that is a possibility that we're seeing it more because we're screening for it. Um, Now, I'm curious. I don't know if there's a way for y'all to communicate this, but I wonder, are you concerned about immunizations being the cause of autism? Some people are. So it's a little bit of a guarded, kind of a controversial subject. So it's super important to look at um, and to learn as much as you can about the variety of ways for your children to be immunized if they need to be immunized. Um, and you do have in the state of Texas, you have the authority to for religious or health purposes for your child to not be immunized according to the Texas immunization schedule. Um, I will share something like y'all. You're probably all familiar with chicken pox, right? Uh, and there's now a vaccine for chicken pox called varicella. And varicella can be by injection, or it can be by, if it's in an injection, it's one immunization, it's a shot, right? But if you take it in the liquid format, it's two times, and it's a liquid that kids drink. And, it just kind of depends on how you want your children to be introduced to the concept of immunizations, and what your family believes about that kind of exposure. So those are all cultural influences and religious influences that we have to think about. Some other things we have to think about in terms of assessing all of this um, are the influences of the past. The APA, which is the American Psychiatric Association, said in 2022, influence the perception of autistic behavior, culture does, the perceived salience of some behaviors over others, and the expectation for children child behavior, and parental practices. So let's talk about what that might mean. Unfortunately, in the vernacular, in the world that we live in, people think of someone who has autism as maybe they are mute or deaf, or they slap their hands, or they're not capable um, of having those behaviors shaped or formed in any way. And the reality is that that's not true. Um, as we come to meet and understand what's happening with children when they might not speak, or when they may seem like they don't hear, or when they may flail their hands. There's usually a rationale behind it. And the challenge is really on us to help um, be good behavior detectives and help figure out what that's about and help them figure out what that's about. And then to see if we can channel it in a certain way. Over the years, I've seen a good number of children with autism concerns that they may flap their hands when they're talking, right? Or they may flap their hands when they're walking. And learning how to play a basic drum is a good way to expend some energy. And sometimes that's simply about pent up energy. Sometimes it's about a child feeling like they don't have a voice and they use their hands as a way to communicate that they're trying to say something. So we have to have a mindset of, as a parent, I'm a little bit of a detective too, trying to figure out what's going on with that. Because when you look at the reverse of it, you look at the world that we've created for them and how we have it set up a certain way, from their perspective, it might feel kind of alienating. It might feel awkward. So, the more we can learn about their perception and how things feel, how their five senses are inside of the world, and inside of themselves, um, the better that we can do for them. So culture in the vernacular of society, right? Now, culture within an individual culture, it varies. There are some nationalities, some races, some religious groups that are more attuned to the nuances of a child's behavior or needs. And so it's less of a spectacle and it's more of it's just a part of being us, right? It's just part of navigating that situation. So, um, now we saw that with the boys, it's four times more likely to happen with boys. um, Girls do also sometimes have this diagnosis, but it's usually diagnosed later than it is with the boys. So a lot of times with the girls, there might not be an intellectual delay, um, and they might have better reciprocity in reciprocal conversations. Um, they might have more interests and they may master some things a little bit differently than some others. Um, that doesn't mean that their outcomes are necessarily um, different. Um, in fact, it can be a little bit difficult if it's when it's diagnosed later, because then there's some confusion about how long they may have um, suffered any sort of bullying or name calling in a school environment, because the condition was not recognized, right? So how do we want to identify the signs and symptoms? Well, do all individuals with autism spectrum disorder present with all of the signs and symptoms? I don't know. What do you think? I think your best guess would be no, it's going to be different. It's kind of like if somebody gets the flu, people are going to get different symptoms of the flu, right? But there are some key features that are unique to every person. The places in the domains of their life where you will see um, how the autism manifests itself is in their social communication, also considered their interaction skills. That's like their ability to greet people, to shake somebody's hand and introduce themselves, right? um, or to recognize when someone else is new to the group and they haven't introduced themselves, right? So that's about those kinds of social skills. It's also about like holding the car door for a girl or opening the door for a woman. Um, those social skills, they might have them and they might use them when they're prompted, but they might not always think about them. And sometimes that's because 'cause they're honestly thinking about something else. It's not because they're trying to be, disruptive in any way. It's that their mindset is somewhere else. But with repetition and with positive reinforcement, they can learn those skills. Um, Another common area to autism is restrictive and repetitive behaviors. These might fall along the lines of self-stimulating behaviors, lining up toys all in a row, echolalia, and a need for more of routine structure. Now, I want to hone in and unpack these a little bit more. Self stimulating behavior, um, it can be in lots of ways. It might be like kids twirling their hair, right? It might be kids tapping. It can be things that are related to how material might feel on their physical body. Um, so they might prefer a particular type of fabric over another. Um, and, if they happen to appreciate a silk over a cotton, that doesn't have anything to do with gender at all. It just has to do with how it feels on their body, right? Um, when kids line up toys in a row, um, now, if you were to do that yourself, and this is an important way to be a detective, is when we see kids do things and we wonder why are they doing that? Sometimes if we get on the floor with them and we do it with them or we do it ourselves, we get a perspective of what they're seeing. And when kids are lining up toys in a row, they might be counting wheels on cars. They might be looking in each car that they're lining up and they're seeing if they all have a review mirror. They might be lining them up according to color. They might be lining them up according to how they use them, right? So being able to be a detective and to get down there and look at what has my child's attention, that can be really helpful because then you can be attuned with them in that process of what has their attention. And when we share that attunement, it helps children who are on the autism spectrum to gain some of the social skills to communicate because we're right there with them. We're not looking at them and observing them from afar away and trying to figure out what's happening. We're right there with them and we're learning what's happening. Um, I did work with a little boy who he was 4 years old and he could take apart things like you just couldn't imagine. He took apart the kitchen table. He did in their family home. He got the right tools because he wanted to see how it was put together. That child had such curiosity. Still does today. Yeah. So a lot of that is about curiosity and trying to see how things work. And it's not a learning deficit, it's a learning difference. They learn differently, right? Now, I'm not sure if you've heard the term echolalia. The first time I heard this term, I was probably about 11 years old, and my brother had echolalia, and what that is a process of neurologically when someone has made a statement of some type and they're still trying to figure out if they have said it correctly, their lips will move, but no words will come out. It's like an echo from the lips, from not the sound, but the formation of the lips, trying to figure out, did I say that right? An example might be a 7-year-old boy at a birthday party um, asks, "May I have a piece of cake, please?" But then his lips say, he practices it again. You don't hear it, you just see the movement. And in his eyes, he may still be looking at the person or he may look away. But the phrase that he said, neurologically, there's a little element of self-doubt of how it's come across. Now, this is especially um, evident for children on the autism spectrum who are multilingual, that while they're trying to sort out two sets of vocabulary or more sets of vocabulary, we might see more echolalia. Now, that it's not a bad thing, and it's not something that you want to punish a child for. But you would share it with a speech therapist and help the child really develop their confidence in their vocabulary. And a speech therapist can really help parents help their kids develop confidence and competence in their vocabulary. So please don't be alarmed or discouraged if you see that, and please just encourage your children if your other children see it in one child, or your child begins to recognize that they are doing that and they wonder why, um, then you can let them know that's just your mind checking on how you said what you said. And it's very normal for us to do that. It's kind of like when we leave one room to go get something and we get in another room and we don't remember what we were going to the other room for, and we back up our tracks to figure it out, right? That's kind of how echolalia works in the brain for someone who um, is on the autism spectrum. So, those are some important features. Some other characteristics might be, I really want to make sure that we unpack this first one. Um, the word gross and fine motor skills coordination. Gross is used in the way of thinking about the bigger muscles of our bodies, like your shoulders, your hips, your thighs. When you can use those bigger muscles to climb the stairs on a slide, or when you can use those bigger muscles to move across a what we call monkey bars. Um, if you can use your legs and your arms to make your swing go faster, that's what gross means. It doesn't mean gross like it's dirty or it's nasty. It means gross like the child is developing appropriately and those big muscles are able to be used in the way they were intended. And the fine motor skills are like holding a pencil or um, using a zipper or being able to button something, right? That's the application of the hands of fine motor skills. Fine motor skills can also be in the feet. It's the ability to put their feet into their shoes and then to tie their shoes, right? Um, and then it's the goal of putting all that together, of being able to use your gross muscle skills and your fine motor skills and bringing that into, over time, into coordination with each other, right? Now, certainly across all kids, regardless of autism spectrum, we're going to see kids who are just clumsy, right? Kids who just they're getting used to having growth spurts, right? Um, so I don't want you to be alarmed when kids are having clumsy situations or feeling a little bit awkward. You're looking at when those things take longer than normal, right? Um, and it's good to have a set of the University of Pittsburgh out of their child development center. They have a really good list of the ages and stages of kids and really what accomplishments they ought to be able to have physically, developmentally, educationally, speech. And if y'all'd like a copy of that, I can send that to you from the University of Pittsburgh. It's a great document. So you can kind of check off, yeah, 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 I see this in my kid, or no, I don't see this in my child, and I'm worried about it. Or my other children, I have seen it, but this child I didn't. So um, the third column you see there is your delayed language skills, delayed cognitive or learning skills, and sensory issues. And um, this is where it gets a little bit sensitive for parents because we know our kids intimately, but when they get into school, if we have a teacher or someone that challenges, whether our child knows how to turn the pages of a book or if they know the letters of the alphabet. Um, we have probably observed those things in our child before we enrolled them in school. But with some children on the autism spectrum, when they get into a social academic situation, um, there can be a greater difficulty in showing those skills, in demonstrating those skills. Um, so, what can we do about that ahead of time? Well, because we know that in that social situation where there are more people watching, and we know, like with echolalia, they want to make sure they're doing it right. Then we want to let them practice school at home. It's a wonderful thing to play school at home at a very early age to teach them about a relationship with a teacher, about how long we stay on task, and that um, how bells work. Um, the bells and alarms in some schools are very different, one school from the other. And when we do get our children who are on the autism spectrum ready to go to a school, it's often pretty important for us to become familiar with their bell and alarm systems so that we can prepare our children for that by building up their tolerance to whatever type of bell or alarm system that might be. Even fire drills and tornado drills, things like that, because their sensory is can certainly be impacted. So, but again, it really is about preparation and setting up that environment at an early age so that they can learn and practice. And for us to all know what developmental tasks ought to be happening at certain times and then when they're not. So we can kind of handle that. Now, what about adults? What if it's something that wasn't recognized? Um, but we know an adult that has difficulty in social settings. They prefer to be alone. They have deficits in social reciprocity. Like they're not, somebody asks them to coffee, but maybe they don't ask somebody else to coffee or ask that same person to coffee, right? Sometimes with adults, there may be verbal and nonverbal communication. Um, for some persons on the autism spectrum disorder, making eye contact feels like a violation of the soul, like they're taking someone else in, or they're giving up a part of themselves. And so teaching children, um, teaching adults too, about how to have eye contact, when and with whom to maintain eye contact, can be really important features. Part of it is also about what they think about when they're making the eye contact. So sometimes they may respond in blunt ways. Sometimes that's because they think they won't have a chance to say what they need to say, so they start talking really, really fast, and they try to make sure that there's not a pause so that nobody else can get anything in until they have said what they need to say. And sometimes that's because they take things very, very literally, and so we have to teach them by example the difference between figurative and literal. Figurative and literal. For example, if I were to say to a child when it's getting ready to go to bed and they're old enough and I were to say, "It's time to hit the sack." For most of us, that would mean it's time to go to bed, right? But some children might make it literally, "Look at that cutie pie." Ah, yes, that child might think, "Oh, I need to go find a sack and hit it," right? But so being able to break things down. Um, yes, routine is so important. Keeping a schedule as close to normal as possible, helping kids learn how to apply their senses, um, adopting subtle stimming behaviors. We see that a lot in adults of like tapping pencils or clicking pens. Now, does that mean that somebody is suffering that condition? It could be. Um, this masking behavior in adults of imitating speech and body language of other people, that's a lot like echolalia, right? But we see it in a different form in an adult and sometimes forcing eye contact. And that can feel really weird if somebody's trying to make you look them in the eye. And it begs the question, well, why would they do that? Well, because they're looking for some comfort in that. So we are at 7:46, and we do have a video. Um, and I'm hoping that this will play for you guys. If we have a difficulty with it, then we will make sure that we get the link to everybody, okay? Okay. This is Inside Autism.
There's no sound.
Would it be possible to raise the sound on the video?
Yeah, let me pause that for a second and let me see if we can do that or see if it might be my device that needs the change there. Okay, there we go. Okay. Is that better?
Yeah, we're still not able, at least I'm not able to hear. I'm not sure if that's the case with other people. We can see the screen, but we can't hear.
Okay. Let's see if there is another way to do that then. What is the setting? Setting is good. Audio is there. Oh, let's see if that will help. Let me try that. No. Okay. I think what I'm going to do then is let me take this link and copy, and looking for our board here. Oh, I thought we had a chat. Do we have a chat?
Yes, we do.
Okay.
If you go, I'm assuming that you can see the same screen that we can at the bottom. Has
Mm-hmm.
participants and then it has chat, reactions.
Enlarge that. Enlarge that. And oh, there we are, right there. Okay. Okay, what I'd ask y'all to do then is it's about a 3-minute video. If y'all want to watch that in another browser, and then we'll come back, okay? Is that okay? Okay. Just give me a thumbs up when you're back. All righty, very good. So am I understanding everybody's been able to see the video? Good, 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 good. Well, I hope that it's helpful, and I really want to encourage you with the tools that we have from these sessions. Some of these you might like the video. You could use the video to demonstrate to another person the value in entering into a relationship and providing care and support and a predictable environment for individuals, right? Um, so with any of these that we do, I think we're going to do two, or maybe we're going to do three or four, but we want to look at really that ability to, with each of these events, um, to leave with what did I what was I surprised by learning in this session? What am I going to do with something that I've learned? Like, might I use the video with someone I know who doesn't really understand autism? Um, Part of that video, well, the video is from Autism Speaks, which is a national organization that supports the ongoing research for autism, right? And so that's another tidbit that you might be able to share with other people um, about autism. So yeah, let me make sure that that's there. Okay. So when we meet next, we will look at the DSM-5 TR. I'm going to show you a picture of the DSM-5. It's this book. I'm doing this because if you're in a place where for yourself or your child, you want to make sure that the clinician is using the accurate documents, the right books. They're not just relying on their own definitions. And I say that because, for example, in this particular book, now I know you can't see this, but um, if you ever do look, you can look at any library, and these are in the library. Um, but it helps the person who's evaluating to be able to discern if the symptoms that they're seeing in an individual, if they are attention deficit disorder, if they are schizophrenia, schizoaffective disorder, a bipolar disorder 1 or 2. Now, and you see here now, this is why it's so important that children are adequately assessed and that adults are adequately assessed, because it would be terrible to have the wrong diagnosis and be treated for the wrong thing, right? We want to make sure that our children get the right treatment, and that the adults that may be on the spectrum um, are receiving what they need to receive. I also want to encourage you that in the DSM 5 TR, you will not see this listed as Asperger's. It shouldn't be spoken of as Asperger's, and that is because um, for the period of time that it was, the condition was called Asperger's because of a doctor who misused children in concentration camps, and and he said that he found this condition, and he really didn't find the condition. It was other people who found the condition, um, and um, and unfortunately, he got a whole lot of positive reputation from that, but he was not a good man, and unfortunately, there's a whole another lesson behind that with Dr. Asperger. But so we don't call it that. If you are with a professional and they call it that, that should tell you that they're certainly behind the times and are not aware of how that was a misuse. So, can you please provide some ideas on how to improve our classes? I lead the 3 to 5 year olds. Oh gosh, that's a great question. 3 to 5 year olds. Um, Now, if a class is an hour, most kids in that age group are going to need to change tasks about every 5 to 10 minutes, because that's about how long their attention span is as toddlers. But here's a trick that might be helpful. is an egg timer. For the duration of time that you have kids, you want to help them be able to grow their attention and focus, right? So, the first time you're with them, you might tell them we're going to do a task for 5 minutes and do something different. And the next time we're going to do it for 7 minutes. And then we're going to do it for 9 minutes. And over time, we're going to build up their attention and focus on individual tasks. This age group of 3 to 5 year olds, they are also they're still learning with their mouths, and they're still learning with their hands, and so um, kind of alternating between physical activities and listening activities and going back and forth can be really good with that. Some of our children are in the spectrum and already turned 6. When is it appropriate for us to send them to a higher demanding level? It's important to assess. And there are some assessment screening tools that parents can use. Um, and I don't think I've included those, but I will. So I'm going to follow up with the University of Pittsburgh's child growth and development list and the process of how you can assess a child and figure out what's the next right thing for them. There was another statement in here that was really super important. Well, they're all important, but about the Corelle dishes. I had forgotten that. I really appreciate y'all thinking about that. Um, those dishes, that did affect a lot of people. I mean, because, we as a society, we might cook a meal and then wrap that plate up in foil and heat it up in the oven or in the microwave and without the foil, but that just made that lead all the more integrated into the food that someone would digest, right? And there was a note here about the dopamine level and in echolalia, and that is also very accurate, right on the money. Y'all know your stuff. Um, our kids do need to have their dopamine and serotonin needs to be balanced, and some of their behaviors are even though they don't know it consciously, subconsciously, the things that they're doing are to balance their serotonin and their dopamine. So, all righty. My apologies about the video. We'll be prepared the next time for that. I'm not sure what happened with the sound, but I'm glad y'all could all um, do that alternative and watch it on a backup browser. And gosh, other questions? I'm making a note of those things that I need to follow up on. So, for sure, University of Pittsburgh and the 3 to 5 year olds and when to advance. All righty. Other thoughts or questions right now?
Well, Alexandra, I just wanted to thank you. I think it's a fantastic start. A lot of parents have had exposure because of personal circumstances
Yes.
or families that are coming in with,
Hmm.
I guess you could say, sort of adult children. They're in their early 20s, teenagers. And I think just a growing sensitivity by exposure to different families and individuals. And I think this is just a tremendous asset for us to be able to draw from. It really, I think, in many ways reflects this new openness that our community has. And I think that
Yes.
could potentially in the future help other synagogues and other Jewish communities to be able to work with these unique individuals.
Absolutely. Yes. Yes. There is lots of hope. Yeah. The best way someone shared this with me recently that hope is healthy outcomes from positive experiences. When we use it as an acronym like that and we treat our children that way and we treat ourselves that way, we increase the likelihood that that situations are easier to manage and easier to accept, and our kids aren't going to necessarily experience an abrasion about being on the spectrum, right? Yeah. There's some good things about being on the spectrum, y'all. There's a lot of really good things about being on the spectrum. Yeah. All righty. Well, I hope y'all all have a wonderful night, and I'm sure that y'all will let me know if it'll be which Sunday in the future. I'll be ready.
Thank you so much, Alexandra. We truly appreciate it.
All righty. Y'all have a good night. Thanks a bunch.
You too. Thank you.
Bye bye.